All right, good morning, everybody. I know we had a lot of people sign up for this, and as you know, they'll be trickling in, but I think out of respect to all of us who are here on time, we're going to go ahead and get started, even if it's a few minutes late. So I'm Mark Froimson, and it's a real pleasure for me to moderate this symposium with my colleagues, who I'll introduce in a minute. And first, just thank you for coming out. Thank you for your interest in solving periprosthetic joint infections. I think, you know, we're both optimistic and humble. We're optimistic because we think that we have something special here, something that's going to make a real difference for our patients, something that may actually change the story of PJI. But we're humble because we want to hear from you. We want to, you know, we've all been told things like that in the past about innovation and advances. So, you know, we're not getting ahead of ourselves, but I think you'll hear a lot of data this morning about Prontosan, about PHMB that I think you'll find very compelling. I also want to thank our friends. We have a number of folks from B. Braun Europe and B. Braun Global who are here with us, who have been great partners in bringing this to the market. And I want to thank AAHKS for giving us a chance to do this. So with that, why are we doing this? Well, I think that surgical site infection, and particularly PJI, infections after joint replacement, is a modern tragedy. You think about it, patients are coming to us because they can't ski or because they can't play tennis or they want to improve their quality of life. And for those unfortunate few who end up with a prosthetic joint infection, it's a disaster. And I'll just go through this really briefly as an introduction. We don't know what the real number is. Everyone quotes something different. If you look at this paper, it says about 1% to 2%. Maybe it's 0.5%. We're not sure. Most of them develop early. But what we know is it's a real number. And if you operate on enough patients, you will have infections, unfortunately. And we also know it's the most common cause of revision surgery. So it is a real problem. It's not it's not something that doesn't happen. We're revising cases for infection more commonly than we're revising for any other reason. And the problem is, as you may know, the 5-year mortality from a prosthetic joint infection is higher than a lot of common cancers. So these patients don't do well. As much as we're trying to treat them and do what we can do, 2-stage, single stage, this carries a huge morbidity burden and a huge mortality burden. And the cost is quite high. So you're going to go out to the floor and you're going to see robots and AI and all kinds of expensive technology, and yet you'll go back to your institution and say, I want to use some surgical irrigation, and it costs $60 or $100, and they'll be like, that's too expensive. So we have robots that are trying to incrementally change alignment, maybe get range of motion a little bit better. I'm not against it, but we have to be focused also on the biggest problem that we have not yet solved, which is infection. Our mission, and this is why we're doing this, is to get it to 0. 0 is not unattainable. And I would ask you a question. Let's assume the number is 1% or 0.5%. Would you have flown down here if they told you when you got on the plane that it had a 1% chance that it wouldn't land safely? I mean, 1% is high. 1% is a lot. There are 24,000 commercial flights in the US every day, 80,000 altogether. Imagine if 1% were crashing. Imagine if 0.001% weren't landing safely. They'd shut the industry down. And yet we have an industry where 0.5%, 1%, call it what you will, patients coming in for elective surgery are ending up with a severe problem. And this is the data. It's much safer to fly than it is to drive. There hasn't been a commercial airline accident since 2009. And you can see that little circle. That was the one accident. And otherwise, you know it's very safe to get on a commercial flight. So I'm going to go through this very quickly. The point here, because our speakers are going to really speak to this is a statistical contest between the host and the offending microbes. That's all that infection is. It's a contest. And these wounds get contaminated, and we have to resist the infection. And we know OR contamination is real. We've measured it. We know that despite sterile technique and all the things that we try to do, there's still, if you put a culture dish out in the OR, it will be positive for bacteria. And this isn't a new recognition. This is from 1957. Wound contamination, we've known about it. We've just not had an ability to really address it in an effective way. And we know about it. We use prophylactic antibiotics, right? Why do we use those? Because we know that at some point during the procedure, there's going to be bacteria in that incision. And we hope to prime the host, but we have to use wound irrigation, and I think we're seeing this. The choice of agents matter. Others are going to talk more about this, so I'm going to skip it. But we came upon polyhexanide, PHMB, and the purpose of this symposium is to make you aware of it, make you understand this is a choice that you have. I'm wearing contact lenses. It's in contact lens solution. It's incredibly safe. It's in cosmetics. It's in the food industry. This is a widely used chemical to prevent bacterial overgrowth in a huge array of industries. We've just not seen it in orthopedics. So we're thinking, well, what is this? It's something new, it's something strange. It's really been out for a long time. It's very similar to CHG, but it's kind of detoxified. It's much safer than CHG. You don't have to rinse it out. The body likes this stuff, and you'll hear a little bit more about that. I'm going to skip this because, you know, how do you choose an irrigation solution? Some of our speakers are going to address this. But what I want to leave you with, and I want you to think about, do any of you use tranexamic acid in your practice? Right? Everybody does, right? Everybody uses it. But if you go back 15 years ago, nobody used it, right? Transfusion rates were somewhere between 10 and 30%. It was one of the reasons you really couldn't do surgery in an outpatient center. Everyone thinks that the move to the ASC has been because of all kinds of other things, but it's really because of TXA. It's really the fact that we can confidently operate on people and know that we don't have to transfuse them. But you'd never heard of it. It was identified in 1962. It was used in other areas of medicine for a long time, and then one day it was discovered, 2008. And now transfusions are extraordinarily rare. They happen, but they're rare. So the question I have is, and what I'm hoping is, can this same story play out for PHMB? Can we take a chemical that was known to be safe, is used extensively, we have a broad experience with it, and maybe finally we can get the number of periprosthetic joint infections down significantly. So we have a great faculty. We have myself, with the exception of myself. You know, we have Curtis Hartman from Nebraska, Steve Percival, who is going to come in via Zoom from Manchester or Liverpool, England. Paul Jacob, one of our former fellows who set the bar so high no one else has been able to get there. And one of my former partners, Victor Krebs, all very well recognized experts in this field, so we're really delighted to have them. Here's our agenda, but without further ado, I'm going to ask Curtis Hartman to come up and give his talk.